Shifa.
Hi, Sarah.
Good to have you here.
Thank you for inviting me.
No problem at all. So we met in hospital pharmacy and we ended up collaborating on transition care research. And since hospital pharmacy, I moved into pharmaceutical strategy and I've been working on how companies in the pharmaceutical industry partner with patients. So it's quite with your clinical background, you're on the clinical side. It's quite a nice combination of kind of skills to bring together in our research. So do you want to share a little bit about what you do on the clinical side? Because I know your roles are multifaceted.
Yeah, so I've always been in hospital. So as you said, Sarah, like we met in hospital, and my specialist area is pediatrics. And I'm currently working at the Evelina Children's Hospital, which is part of Guy's and St Thomas's, and I do that role predominantly. And then one day a week, I also work for Hospital at Home in Northwest London. And then on top of that, I have a few like national committee roles. So vice chair for the neonatal and pediatric pharmacy group is one of them. And I also sit on the MPPG RCPCH medicines committee as well.
Very busy. So you also work on healthcare research in transition care. It might be helpful to kind of talk a little bit about why that's so important, researching the transition of patients from pediatric to adult care.
Yeah, so it's actually really interesting, and I think it's come from observations in clinical practice. So before I really specialized into pediatrics, I did work as a cystic fibrosis pharmacist,
Mm.
and that was on an adult ward, and that was a very different experience for me. And a lot of the conversations came back to, so I guess, one of the things to know about CF is it's a disease that you're born with, and it
Mm.
can mean that patients are on a real number of medications. And
Mm.
conversations we were having very much struck me that part of, I suppose, their challenge is that
Mm.
they have had that disease from day one of life,
Mm.
and they've been taking medicines all through their childhood. And now, as adults, we're expecting them to have, autonomy over making decisions. And then, actually, I think a lot of the conversations I had, young people said to me, well, look, I don't really understand why I take these medicines. I don't really know how they work. And then what that translated into then was problems with adherence. And we know with CF and other long-term diseases, actually that can have really, significant consequences on, long-term outcomes and their health. So actually it sort of struck me that actually, there's something missing here. And then when I went back into pediatric services, and just observations, talking to young people, but also seeing how healthcare professionals talk to children. Again, it felt like there was more that we could do. So that what we didn't have is that when those young people went into adult services, like those CF patients, that we
Mm.
didn't still have those gaps in knowledge where people felt they didn't have, all the information that they needed to know to be able to make decisions about their own health.
When we worked on the children's and young people's perceptions study together, the success study, which was about what children need um, from the transition process and what their barriers are and their general experiences. We involved the children and the young people throughout, from study methods through to publication as co-researchers and co-authors. And when we started, we looked for practical examples of involving the children and young people across, research and publications. I don't know if you remember our search for someone who has done this before in a paper that has done this before, and we couldn't really find anything, could we? There wasn't much out there.
No, and I suppose there's a couple of things there. So I think if you think back to when we were coming to publication and thinking about affiliations,
Mm.
actually, so because we had young people, we use their schools, but there
Mm.
isn't really a way that I'm aware of when you're publishing for it to be quite obvious, like who the authors are that have lived experience. So when you're searching, then I don't know that there's a way of actually being able to search journals to say, actually, I want to find journals that have authors who are, either children or adults with lived
Mm.
experience. So I don't think that journals yet have found like that keyword or whatever it would be for us to be able to find those
Mm.
journals. I do know that there are particular journals that are sort of patient, I guess, focus journals perhaps that
Mm.
might have things. There is, there is project work. So I know like Great Ormond Street and Evelina and other children's hospitals do a lot of this work. I think then what was probably quite unique about what we did was then taking that work to publication and actually using the young people as co-authors. I
Mm.
think there is a lot of work that is happening where people are co-producing work with children and young people.
Mm.
I'm just not clear that that then leads to an output like a publication where they then meaningfully contribute as co-authors as well. And I think that
Mm.
was really nice for our young people to actually be involved, like you said, from conception of the idea all the way through to publication. And I think
Mm.
that's quite novel. And that certainly came up, didn't it, at the conference that you and I both went to, where industry partners definitely commented that this was something fairly new for adults, let alone for children and young people.
Yeah. And I think um, as part of that search for the publications that had done this before, we wanted the main reason we were looking for publications that had children and young people as co-authors is because we wanted to see their process. Because in industry, at least, there's a very it's very kind of guideline heavy, and there are requirements and best practices that we need to follow. So from my perspective, that's why it was important to kind of look for that process. But when we didn't see much out there, we ended up designing our own. So we had a process that involved feasibility assessments, alignment with publications criteria, age appropriate communication. There was actually quite a lot to that process. So I guess did you find that having that structured process enabled participation that happened without wouldn't have been able to happen without that structured process? It wouldn't have happened otherwise?
Yeah, and I think actually the nice thing about getting it, so obviously we did ours as a research study, so it went through the Health Research Authority and we had to get ethics approval. And I think the nice thing about doing all of that is as part of your submission, you will get guidance on, is the information you're giving children, young people appropriate for their age? Is the material you're giving to an 11-year-old, is that going to be the same as what you might give to a 16-year-old, for example?
Mhm.
But then that means that actually they can meaningfully contribute because they actually understand what you're saying because you're talking to them in a language that's age appropriate for them. In terms of ethics, I suppose you know that you've got the assent and consent forms that you need. And you do need all of that if you're going to want to publish your work, because without having all of that behind you, you
Mhm.
then would find it very difficult, I think, to publish in a peer-reviewed journal. Because the first question they're going to ask is if you've got young people, well, do you have ethics approval to be able to
Mhm.
do this?
Yeah. And it meant that it felt like a collaborative process with the
Absolutely.
children and the young people. They were able to genuinely make their contributions and not just nice to have perspectives. They were really decision critical insights as well, weren't they? Which it makes me think we've increasingly been thinking about patients and caregivers as experts in lived experience. Um, So, what are your thoughts based on your experiences in research and also clinically on what patients and caregivers and people with lived experience can identify that researchers and clinicians would never come across on their own?
Yeah, it's a really good question, Sarah. And I think it actually comes down to even the research question itself. Because
Mm.
I think we, when I say we, I mean healthcare professionals, we might think that something is a problem. But
Mm,
actually, children and young people might say to us, actually, that's not what we think the problem is. We actually think the problem is something completely different that you've never even thought of. So I can't remember what hospital it was, but they did I think it was something to do with outpatients or waiting times. And the healthcare professionals had decided that what they thought the problem was, and they were going to go away and do interventions. And then they spoke to patients, and they actually said that we don't mind that at all. What we mind was things like not having water, or not having this, or not having this. So things that I guess maybe we wouldn't even think about as
mm,
healthcare professionals. So I think there's one thing about actually, is the question truly reflecting the needs of, the audience?
mm,
But I think there's a second thing about actually then when you come to implementation, so
mm,
you've done your study, you found, your findings, when you're thinking about your recommendations and what you think should happen next,
mm,
if those don't really echo like lived experience, I almost feel like you're going to fail because you might try and sort of implement things without having considered the wider picture and the things that actually really matter that may not actually be what you think.
mm,
Um, and I think it's about adding more and more perspective. So when you do any change management project and you're asked to identify your stakeholders, this
mm,
is very similar, isn't it? It's thinking
mm,
about actually who is this for? Um, Presumably you're trying to do whatever it is to improve patient safety or patient experience. So actually, if that's your goal, then
mm,
actually you need to know that it's going to make a real difference. And you can't really do that without hearing from them actually what's important to you, what would make a difference to
mm,
you, and almost what does success look like to you
mm.
as well.
It seems so obvious when you put it
It
like
does.
that, but I think I remember when we were at ISMAP together, quite a few of the perspectives were quite surprising from a clinical perspective, but from an industry perspective, we there are recurring kind of not exactly barriers, but kind of concerns because it's such a regulated area. So no one really questioned whether the young people and the children should be extensively involved, but all the questions were quite practical, like
Yeah.
how did you do this? How did you handle informed consent and autonomy? And, we talked about having to talk to parents and schools and so on. So I guess whether did any of those perspectives surprise you, or did they stand out compared with the clinical practice setting that you're used to?
I think, yeah, I guess it's very interesting because when you're in clinical practice, as a pharmacist, this is just what you do every day. So when you're on a pediatric ward, you're talking to children, you're talking to their parents, you're getting consent for things like taking a drug history, or if you need to contact the GP, you need to ask for that. Um, if you're using the discharge medicine service, you need to ask for consent for that. So I think we're quite used to as clinicians, talking to families, talking to children, um, you know, trying to decide, who who is appropriate. And it's often both that you want to, listen to and involve, and then thinking about
Mm,
assent and consent. So I suppose it's it's not surprising from a clinical perspective, but I can see from an industry perspective
mm,
um, how that could be a challenge, particularly if you're not used to talking to children and young people. And I think that still goes across clinical practice. I think when we've spoken to clinicians who don't normally talk to children, so for example, if I talk to my adult colleagues, they will say they can think of nothing worse than going on to a pediatric ward and having to talk to a child because I just think it's not what you're used to
Yeah.
doing. So I think this probably shows the value of actually making sure, you're partnering with the right people. So for example, when you and I did the work
Mm,
together, I think we both brought our expertise and our skills,
mm,
but you have skills I don't have, and vice versa. And so together it worked really well. But I
mm,
think it shows that actually you do need to have people who have that, the experience of working with children and young people, who is very comfortable having those conversations, who knows how to take consent from families, because I think what you don't want is someone. you know, and I've seen it happen before, like when you go and talk to families, as soon as you say, like, oh, we're doing a study, like there is naturally going to be this, oh, like, what is this study? Um, so I think it's very much about explaining, the benefits of the study, why you should be involved, and so on. And I think that's reflective of the numbers we got for the study that we did,
Mm,
was that the participants who couldn't take part in the study was for, clinical reasons rather than
mm.
actually, um, saying, actually, I don't want to take part in the study because of personal reasons.
Yeah, yeah, for sure. Almost everyone who was eligible were able to take part in the study and obviously
Absolutely.
felt comfortable in taking part in the study.
Mm.
And that kind of ties into one of our recommendations that we talked about for if someone in industry is looking to work on involving children and young people from an early stage. One of our recommendations was having a person on board who is experienced in pediatrics, who is experienced in talking about critical health information with children. And also, I mean, you have skills and techniques that you use that might not be visible to other people, like checking that they've understood what you've said. There's the teach back techniques and things like that. Um, I guess you find that you must use them quite a lot when making sure that consent is truly informed.
Absolutely, because what you don't want is that people, like for consent to really be done like ethically, you need people to understand what they're doing. They understand they have the right to withdraw at any time. And these are all the things that you will go through. You're going to explain how you're going to use the data, for example.
Mm.
And so it's really important to think about that. And also when you're having conversations with people, um, I guess it's, things to think about actually, is English their first language? Like there are lots of things to think about, isn't it? And actually it's quite interesting because sometimes we find when we're talking to families that actually children are the experts over their parents. So because it's the child themselves that's taking the medication, they know how they feel, they know what side effects. And so I guess it's about because depending on the age of the child, obviously that the consent probably doesn't mean much to very young children, but it's about making sure that parents understand, that we're going to use the information that the child is given to us.
That's really interesting because I think maybe the default and the what is viewed as the less risky option in industries perhaps to talk to the parents, but there you've said that children are obviously have more knowledge than parents about what they're doing. So that's really interesting. Do you think there's value in maybe speaking to both the parents and the children to kind of maybe in your recommendations when you're interpreting findings to bridge that gap?
Yes, but I think it's about being quite mindful that the children's perspective is truly their perspective as opposed to what they think their parent might want them to say. And also, Sarah, there is something in there about bias for when healthcare professionals are talking to both children and adults about people answering in a way that they think that you want them to answer as well, isn't
Mhm.
there? Um, but definitely, I would say it's important to get both perspectives. And actually, what would be very interesting would be to see how those perspectives compare. Um, but I would say it's if you're going to do research with children, it's very important that it's the child's voice that's coming to you, and it's not the parent saying, "Oh, such and such thinks this." It's actually the child saying, "Actually, this is how I feel. This is what I think."
So you talked about early involvement, and there's quite a lot of solid data behind this now. We're seeing that involving patients in design, endpoint selection leads to positive outcomes. When they involve patients early, they're more likely to meet their endpoints. The cost of delays and amendments is reduced. So getting it right from the start is strategically important from that perspective, but also obviously it gives you the relevant insights that actually make a difference to patients' lives. So I wonder whether that is reflected in from the clinical side. Are you able to compare situations where um, patient input has been early and then see the outcomes of that versus there hasn't been any patient situations where there hasn't been any patient input, and how does that affect outcomes?
I think we still see both, Sarah. I think
Mhm.
you see examples of excellence, and then you also see projects that you think, oh, like, why was no one, like, adult or child, depending on, where it is, why was nobody with lived experience involved with this?
Mm. Okay.
Um, but, there are, like I said, there are examples of good practice. Even if I think about nice guideline committee work that I do,
Mm.
we always have lay people on there and listen to their experiences, making
Mm.
sure that anything we write really, you're listening to them and their concerns as well. So I think we're moving in that direction. I think my challenge back would be that definitely listening to what you've said and also listening to the experiences at the ISMAP conference we went to, is we're starting to see this in adults. I think the challenge now would be actually, why can't we do this also for children and young people as well? And thinking about how you can meaningfully involve them.
Mm. What would you say are the next steps to making that more of a reality, bringing children and young people in early?
And I think you said it early on, Sarah, which was about the barriers, or I don't know if they're perceived barriers or barriers, especially from an industry perspective. I think we've shown from an NHS clinical perspective it's entirely possible to do. So I think it'll be more people following that model. And I
Mm.
guess from an industry perspective, thinking through what those barriers are and
Mm.
then how you can navigate those barriers.
It's interesting that you bring up perceived barriers. I remember you answering someone's question about how did you manage to deal with the affiliation issue when obviously children don't have
Well,
workplaces.
yes, yeah.
And you answered that question, didn't you?
Yeah, so I mean, for our two young people that we involved, we used their schools as their affiliation, and we helped draft letters to the school to explain, like you said, what does a publication mean? What does it mean to have the child's name? It's also going to have the school's name attached to it as well. And that was our process that we followed.
Yeah.
And so I think it's just being able to explain what you did, rationalize why you did what you did, but then also having the governance behind it. So we didn't just put the schools' names down without actually asking the schools first, like, are you happy with this? And getting a letter back from the school to say that this is okay.
Mm.
Um, and I think it's the same as when you're publishing and you're using um, people like, so for example, when I worked with yourself, what
Mm.
affiliation are you going to use and other stakeholders that you might use as well.
Yeah. Yeah, it's one of those situations where you're not sure whether that barrier is something that just puts people off exploring the research altogether just because it seems like it's too difficult to achieve. But I think someone said it quite nicely when we were at the ISMAP conference that academic and clinical research often is quite trailblazing and provides a
Yeah.
template for other people. So maybe that's um, the answer to next steps. We need more good practice examples. Um, I think in the industry, it's teams agree that patient partnership is valuable, but then they struggle to translate that into meaningful and measurable action. And we hear talk of plain language summaries being a great example. They're often positioned as good engagement practice, but you could argue that they're the minimum standard, really.
Mm.
If you're involving people just at the plain language summary stage, you're missing
Well, you've missed
input.
everything up to that,
Yeah.
haven't
The
you?
input into the research
Yeah.
question, the methodology.
Even the interpretation of the findings, Sarah, I would say,
Yeah.
because I think that's what we found valuable
Mm,
was that obviously we had our own ideas about what the findings meant to us, but we needed the young people to be able
mm,
to add to that. And
mm,
then came the plain language summary after that.
mm.
Whereas if we'd have just said, look, this is what we think, can you go away and develop a plain language summary? We would never have captured any of their ideas and their thoughts on what the findings meant for them.
Yeah, and they had ideas that we hadn't really thought about because like there's not a lot of situations where there's evidence for everything. So you wouldn't find it from your own background research, but then they were able to call on their own experiences, the experiences of friends. I think one of the examples we had was the value of peer networks and social networks for them, um, which doesn't come up much in the evidence, but comes up quite a lot anecdotally. So that was interesting. So talking a little bit more about barriers. What are the barriers that you see clinically? What stops um, teams from embedding that meaningful patient involvement early on when you can influence priorities and endpoints and study design?
Do you know, Sarah, some of it might just be awareness. So it
Okay.
could be that you've just never thought about it. Now, I know we said at the beginning of this conversation, it seems so obvious. Why would you not do it? But clearly, we're seeing so many publications where it's not happened that
Yeah.
it makes you wonder, was it actually nobody thought about it? Was it being able to meaningfully interact with children and young
Mm,
people? So I think, I think it's one thing to recruit children and young people because you have a time point and you're able to speak to them. I
mm,
think if you're wanting to use them as co-authors and really listen to them, that's obviously time that you need to be able to invest into being able to do it. You
yeah.
also need to have the right network though, because you need to be able to follow up with so say from your cohort of children and young people that do your study and you identify a couple of them would like to be
Mm,
involved in as co-authors.
mm,
You then need to be able to have the time to spend with them and the resources to be able to do it. And I think the beauty, I guess, of me knowing these children and young people is like we developed a relationship over time, got to know
mm,
them, got to know like their experience. And I wonder if you're going in just as like a research team and doing that. I
mm,
don't know that you would. I guess I don't know that you would still get those the beauty of those conversations that we
mm,
had and the depth of the answers that we got. So I think there is something in there about actually how well do you know the children and young people?
mm,
Do they trust you as a healthcare
mm.
professional?
Yeah, yeah, exactly. And I think our recommendation is to involve someone like yourself who is experienced in building rapport with children and young people, who is experienced in speaking about critical issues with them. And I think that makes a huge difference. And I do think it's important to recognize that if you're doing something like this, you'll get incredibly huge value and benefit out of involving children and young people early on. You do also need to invest the time
Mm.
and effort and resources to be able to make sure that they can meaningfully contribute, that they feel comfortable contributing, that they actually feel part of the team.
Yeah, and I guess Sarah, the other thing to add is
Mm.
children don't work a 9 to 5:30
Yeah.
day like you and I do.
Yeah.
So I can say to you, like, let's plan a meeting in the diary and we can put a Teams call in, for example. Children will go to school. They'll have extracurricular activities, things at the weekends. I guess it's also that could be another barrier. If you're thinking, well, look, we only work between this time and this time, and the young person's not accessible at that time, then that's not going to work. So I think there is something in there about actually when are they available, when are they free. So I think that's another thing to think about when you're partnering with children and young people is actually um,
Mm.
if you really want to involve them, you've got to sort of fit around their life. They don't fit around your life.
Yeah, yeah, exactly. Because you don't want to cause additional stress. Um, you want to. We made quite a lot of effort finding out when their exam periods are, when would be the best time to even send them the papers
Yeah.
to take a look at. Um, so that was really important. But obviously, it takes a bit of investment, and perhaps in the industry, I'm not sure if this is the same clinically, but teams might be under pressure to show whether these engagement initiatives are working.
Mm.
Like, is the partnership approach meaningful? Is it leading to decisions that are better for patients? How do you tell when patient engagement approaches are genuinely shaping outcomes? How do you measure that impact?
That's a good question. I don't know that you could like quantitatively measure it.
Mm,
I think it's about those insights. As soon as you're getting insights that you didn't have, I think for me that is the success, isn't it? That
yeah.
they've brought their perspectives. Um, that when they look at results, they say, oh, like this means this. And you're like, okay, I didn't think about that.
Mm,
Because what you don't want, and I sort of mentioned this earlier, was that you come out with a product or an intervention,
mm,
but then it's not actually going to work because it's not taking into account like preferences or experience.
mm,
Um, so
mm.
I guess for me, success, or how do you measure that you've got that is actually where you're getting insights that you wouldn't otherwise have got.
No, that absolutely makes sense. And that is where it adds value, I guess, commercially as well, because like you said, if you're coming out with a product that
Mm,
no one will use, that's a huge amount of time and resource
absolutely.
that is
That you put
just
in. Yeah.
wasted, isn't it?
Yeah.
Um, okay, interesting. But I guess does that also are there parallels to that clinically? So I guess you're involving patients early in their care plans, and you want to see whether that has made an impact on adherence and so on. Is that something that you can measure clinically?
Yeah. And I think if you go back to the example I gave you at the beginning, if
Mm,
those young adults on the CF ward,
mm,
um, if you could turn back time, and I guess we don't know, but had they had, the education about their medicines and the side effects and what to expect and so on, um, in that scenario for those particular individuals, I know we don't know, but the literature tells us when we look at transition that there
mm,
is a difference between people who have gone through a formal transition
mm,
process and the outcomes they have compared to children that have not. So
mm,
actually, I would say, based on what we did, absolutely, like the earlier you involve people in their care and shared decision making, which is a
mm,
big thing, and NICE has a guidance on this as well. I guess the whole point of all of this is if you're shaping your own care, then you're more likely to then have better outcomes, aren't you?
mm,
Because it's the decision that you've made for yourself.
mm.
Um, you
Yeah.
have autonomy over it, you're making your own decisions over things.
Mm,
And then I think that independence that it gives you means that you're able to then make better informed decisions as well.
mm, mm. Yeah. So it definitely is worth the effort. It's a bit of a no-brainer. And from the strategy side, we find that patient partnership needs to be planned and budgeted from the start and
Mhm.
not retrofitted. And what I've observed from this process, when you're partnering with children, young people, it is important to have someone like yourself on board, someone with specialist expertise in communicating this sort of health information. And and I guess the last thing to say is that ultimately it's of such huge value and it's worth the effort. And from your perspective, I mean, it's probably clinically, from a clinician's perspective, it's probably a surprise that it isn't done more often.
Absolutely. But we can hope that through conversations like this and the work that we've done, sometimes somebody needs to start something somewhere, don't they? So,
I like that. Somebody needs to start something somewhere. That can be the headline of
yeah.
this conversation. Okay, thank you so much,
No,
Ashifa.
thank you for the
Yes.
opportunity.